Welcome clients and guests to my channel. I'm Jason Serro and I'm a licensed professional counselor. My videos are designed to educate and empower you to make informed decisions about your mental health. Hey everybody, thanks for tuning back in. In my first video, I went over a little bit about an overview of what Dialectical Behavioral Therapy, DBT, actually is. And in this video, I'm going to go over the fact that it's evidence-based and it has been tried and true through various clinical assessments. And today I'm going to give you just a brief overview of what it actually has been tested for. One of them is parasuicidal women with borderline personality disorder. And parasuicidal is, what it means is it's non-fatal self-injury with intent to cause bodily harm or death. And people will use all sorts of methods to do that. They will cut themselves, they will burn themselves, bang their head against the wall, hit themselves, and there's suicidal ideation there. Patients with BPD and substance abuse disorders, and mainly we're looking at alcohol abuse. Number 3, binge eating disorder and bulimia nervosa. It has been proven to drastically reduce those symptoms for those two disorders. Depressed elderly patients with personality disorders. Post-traumatic stress disorder. Half the participants had BPD in this trial, and it was also adapted DBT, which means it wasn't the full program. It had maybe some components that were excluded, and maybe there was another part that wasn't actually DBT. Maybe it was another model that they pulled from. Adolescents diagnosed with bipolar disorder, and for adolescents with suicidal ideation. And bipolar disorder was the main diagnosis, so in that trial, the patients had to have a primary diagnosis of bipolar, and it was proven to be effective for that condition. And skills training for adults with attention deficit hyperactivity disorder, ADHD, which it was a little caveat in there. The patients with ADHD had regular maintenance of their medication. So they were properly medicated, and it was being medicated and getting skills training, which was effective. Number 8, mood disorders for adults. So mood disorders, there's lots of them. There's major depressive disorder, which is a series of depressive symptoms that happens in a certain amount of time, and what you'll see is like a 2-week time period where you have someone can't get out of bed, they're hopeless, they feel lonely or alone, they don't really think about doing much in the day, they can't get to work, they can't get to school. There's a lot of symptoms that happen in a short amount of time. That's a major depressive disorder. And you'll see episodes that we call episodic behavior. Bipolar disorder, which has what's called manic in it, a mania phase, and that's when somebody feels elevated and sometimes feels invincible. They don't require a lot of sleep and can be, easily angered, and then it's followed by a real drop, and that's the depression part. So there's that period of time where they're really elevated. It could be a number of hours to a number of days to even weeks, and it's followed by a real severe drop, and that is the depression really hits. Seasonal affective disorder, cyclothymic disorder, which is an up and down mood, which is less severe than bipolar, so it has similar symptoms to bipolar, but it's just drastically less severe, so still ups and downs in mood. Pre-menstrual dysphoric disorder, dysthymia, which is a low-grade chronic depression. I'll see that a lot in my practice. It is, again, it's kind of like all the depressive disorder symptoms, but at a much lower grade, and doesn't impact people. People who have that are higher functioning, can get to work, don't really miss too much work, but they just feel kind of lousy most of the time. Depression related to medical illness, and depression induced by substances or medication. Finally, disruptive mood dysregulation disorder in children. Originally, it was thought that disruptive mood dysregulation disorder was bipolar disorder for children, but they did some trials and it came out that it's really chronic irritability, which is being easily annoyed and agitated, along with anger in children, and they track them over time. Those kids are at higher risk for anxiety and depression as adults. It is not bipolar. So I'm going to go into the next slide. I'm going to go into how DBT works. DBT has three main components to it: group settings or therapy, individual therapy, and phone consultations or coaching. So in group therapy, it's homogeneous only in diagnosis. So for example, you would have 8 people all diagnosed with borderline personality disorder in that group. Skill training, relationship building, peaks and pits, as I would call them, leadership roles by members to model and show listening skills and empathy. I run a DBT-like group at nighttime, and it's actually through telehealth. And we have a group of about 6 to 7, sometimes 8, 6 to 8 clients that they get to switch roles on being a leader. And it has shown, in my experience, great camaraderie among the group members because they really care. They get to go around asking, hey, what was the best part of your day? What was the worst part of your day? What was the best part of your week? What was the lowest point of your week? And then the group leaders do a wonderful job of really bringing those two, sometimes polarizing parts, and they really mesh it in really well and make sense of it. And they really do care about each other's day. So the members really do feel included and feel like everyone has a voice and everyone cares. In individual therapy, this is where you're applying the learned skills to problem areas in life. This is your one-on-one attention with your therapist. In that setting with your therapist, you do some goal setting, you do some treatment planning, you talk about medication possibilities, you talk about the skills that will be applied. You can, and in my practice, I definitely am upfront about what model I'll put forth. I'll tell, and sometimes my clients already know what I'm doing, and they'll even ask me, hey, can you do CBT? Can you do DBT? And we absolutely negotiate that and figure it out, which one would work best for you. And the therapist in this model has what's called strategic therapist disclosure for modeling. So it's kind of like if someone is struggling with an issue or an internal dilemma, the therapist can strategically talk about maybe something that they went through that really apply. It's not about the therapist. The therapist doesn't take center stage and take over the session, because that does happen with some. But the therapist makes a clear and very particular example out of what the person is struggling with and normalizes it, and can show also problem solving by how the therapist got out of it or how the therapist dealt with it, while also acknowledging maybe it was not successful the first time around, and shows the client that the therapist also is human and obviously goes through struggles themselves. So it's a really strategic, it should be done strategically. It cannot be overdone because the client is the main person that needs to do most of the talking and most of the processing involved, obviously. Number 3, we have phone consultations or coaching in between sessions, helping a client problem solve a crisis or difficult situation. In my years practicing, I've had countless phone conversations at 2 o'clock in the morning because of some crisis. Someone is drinking too much, someone is suicidal, someone just got into a big fight. Coaching that person through the event is critical, because sometimes people don't have anybody but their therapist at that time until we build the network around them. And the therapist can be a lifeline, which is really wonderful. And it's been a wonderful experience being able to help people overcome those really acute crises. So that's all I'm going to talk about for today, and next video I'm going to go into the 4 components of dialectical behavioral therapy. So thanks for watching. Be where you are. Be resilient.